Hi, it's Dr. Jim DuCanto. I'm here to talk to you about those amazing bronchoscopes. In the modern day and age, we have video-driven systems that have reduced the cost and increased the availability. Bronchoscopes are known for their ability to suction through a suction port, as well as administer medication through the working channel or even use instrumentation. Now, the basic controls that I want you to understand is the flexion extension lever, or flexion and retroflexion. With this control knob, we can flex the endoscope or extend the endoscope. When it comes to turning left and right, we simply flex or extend and turn the handle right and left like an aircraft joystick. To prepare for a flexible fiberoptic intubation, I'm going to apply topical local anesthetic to the patient's tongue and posterior pharynx, and then I'm going to place an oropharyngeal airway that is made to assist fiberoptic intubation. This is a Berman oral airway. I'm going to illustrate in this demonstration how to apply topical local anesthetic to the bronchoscope itself. I have suction connected. I'm going to begin with my first syringe of lidocaine. I'd like to use 4%. 10 milliliter syringe with 6 milliliters of air behind 4 milliliters of 4% lidocaine. I'm going to begin my endoscopy through the oral airway. When I reach the bottom of the oral airway, if I want to twist it a little bit to help me maintain the membrane, I'll do that. I'll retroflex the endoscope to go under the epiglottis and look up at the larynx. If I try to approach the larynx without proper topical anesthetic in a otherwise non-anesthetized patient, I'm going to have laryngospasm. So the count of 3, I'm going to administer topical local anesthetic. And this is what I say to my patients. I'm going to administer some medicine to you that's going to make you cough. When you feel like you need to cough, go ahead and cough. Here we go. 1, 2, 3, go. The 6 cc's of air propels the lidocaine onto the patient's vocal cords. It's going to suction out the residual simulated local anesthetic. We're going to give that at least 15 seconds to work before we move to the next phase and administer additional local anesthetic. I'm going to flex the endoscope as I go over the posterior commissure, and I'm looking at the anterior commissure. I'm going to retroflex the endoscope and go down into the trachea. This is going to cause a lot of stimulation to the patient, so you're going to administer a second bolus of local anesthetic to the patient. The patient will cough that medication around and anesthetize the entire trachea to suction out whatever is in there. I'm going to go down to the carina here. I'm just switching hands because what I'm going to do is identify the carina here, and then I'm going to advance my tracheal tube around the base of the tongue, and then I'm going to make sure that the Murphy eye, instead of being at 3 o'clock, I'm going to rotate it so it's at 12 o'clock to minimize the hang up on the larynx, suctioning out residual secretions and local anesthetic. I'm going to identify the carina now. I'm going to deliberately touch the carina, and I'm going to use this as a method to identify the depth of tracheal tube insertion. I'm going to back the bronchoscope up to where the tracheal tube is. The distance between my 2 fingers here shows that I'm 2 centimeters above the carina. Nasally, we would begin by placing a properly lubricated tracheal tube. You want the tip of the tracheal tube to just go to the back of the soft palate, and then you'll introduce your bronchoscope. For this demonstration, I'm using a 5mm Ambu bronchoscope. Coming around the back of the soft palate through the distal tip of the tracheal tube. To the right is the Murphy eye. To the left is the larger lumen. It's the distal tip of the tracheal tube with a left cut bevel. As I see the epiglottis, vallecula, and larynx, I'm going to turn the tracheal tube just a little bit to the right with the 15mm connector to line up on the airway. And then I'm going to push the elevation lever upward, which will actually retroflex the endoscope and allow me to advance. As you can see with my left hand, I'm using this to advance the bronchoscope. I'm going to retroflex the lever again and head down towards the carina. As I reach the carina, I'm going to switch hands with the bronchoscope. This is my dominant hand. So I'll advance the tracheal tube with my dominant hand. I'm going to give the tracheal tube a leftward twist to minimize the gap between the leading edge of the bronchoscope and the left cut bevel of the tracheal tube, and place the tracheal tube all the way to the hub. In this case, it's a 7.0 tube. I'm going to back up the bronchoscope to find the carina and then measure the distance from the tip of the tracheal tube to the carina. I'll now pinch the bronchoscope and back the endoscope up until I reach the beginning of my own tracheal tube, which is right there. So the distance between these 2 fingers here is the distance I'm above the carina.